Hello, care. M. Foscue Brock Institute for Community and Global Health at EVMS. The Brock Institute collaborates within and beyond EVMS to provide education across the region to improve the health of our community. We are grateful to partner with Sentara Healthcare to host this webinar, providing updated clinical information related to COVID-19. We are joined by a very distinguished panel of local medical experts with statewide and national recognition. Dr. Edward Oldfield III is a professor of internal medicine at EVMS and an infectious disease specialist. He will be presenting a broad overview of COVID-19, including the epidemiology, transmission, and presentation of the virus, as well as information on reopening society and progress on a vaccine. Dr. Michael Hooper is an associate professor of internal medicine at EVMS and vice president of medical affairs for Sentara Norfolk General Hospital. He will provide the Sentara Hospital preparedness update, including protocols for infection control and personal protective equipment management. Dr. Paul Merrick is a professor of internal medicine and the division chief of pulmonary and critical care medicine at EVMS. He will be discussing immune dysfunction and thrombophilia as major pathogenetic mechanisms of COVID-19 and approaches to therapy. After our panelists have shared their presentations, there will be a question and answer session facilitated by me. So please submit your questions through the Q&A box on your screen. Let us begin now with Dr. Oldfield.
All right. Good. Can you hear me now? Can you hear me?
Yes, Dr. Oldfield.
Good. All right. Well, a good place to start is with the coronavirus itself. There are 7 that have caused human disease. SARS in 2003 was a bat coronavirus that made a jump from bats to civet cats to humans. The Middle Eastern Respiratory Syndrome, or MERS, was a bat coronavirus that made a jump to camels and then to humans. That started in 2012 and is still ongoing on the Arabian Peninsula. Our current virus, SARS-CoV-2, came from bats by an unknown intermediate animal, maybe a pangolin. There are a couple of major mutations that differentiate it from the original SARS, and the feeling is that these came from natural selection. There's no data whatsoever to suggest that this was bioengineered. An important point for us to remember is that there are over 500 different coronaviruses in bats. So we need to be prepared to see a different coronavirus in the future. Whether this will be a pandemic with peaks and valleys, or whether it will be like the 4 endemic coronaviruses that cause up to 30% of the common cold with recurrent outbreaks every winter, is unknown. But some people feel that there's a good chance that this could become endemic. If you can see at the top, that's the original SARS from 2003, very closely related to the bat virus. And at the bottom is our current SARS-CoV-2, very closely again related to a bat coronavirus. Now this SARS-CoV-2 has a spike glycoprotein, and it uses angiotensin converting enzyme 2, or ACE2, as its cellular receptor. It binds to that receptor, fuses, and then enters into the cell. ACE2 is broadly distributed through the body, and this accounts for some of the wide variety of clinical presentations. One concern has been hypertension as a comorbidity with increased mortality, and concern has been about ACE inhibitors and angiotensin receptor blockers. It appears from multiple studies now that they do not increase severity. And in fact, some of the studies show they may actually make COVID-19 better. Bottom line, if you're on one, don't change. If you aren't on one, don't start. So here we have the spike glycoprotein at the top, and it finds the ACE2 receptor on the cell surface, binds to it, and fuses and enters the cell. For transmissibility, the feeling of essentially all scientists and almost all the data is that this is droplet transmission within 3 feet and a maximum of 6 feet. There is very little, if any, data that suggests that this is airborne like measles or chickenpox. Transmission from surfaces is felt, and environmental contamination is felt to be around 5%, not a major cause of transmission. How infectious is COVID-19? You could say not very. A study of the first 10 US imported cases with 445 close contacts, only 2 became infected. Both were household contacts, so 0.45% overall, 10% for household contacts. But you could also look at these super spreader events. The Biogen meeting in Boston with 175 attendees, nobody was symptomatic, 77 infected. And now infamous church choir practice in Washington State, no one symptomatic, 61 members, 53 infected, 2 died. An estimate from Virginia Tech environmental engineers suggests that there may be up to 1,000-fold individual difference in the amount of virus exhaled with speaking and coughing. That has led to an estimate that 10% of cases are responsible for 90% of transmission. Pre-symptomatic transmission is an issue that is going to make this very difficult to control. Transmission begins 1 to 5 days before symptom onset, and the viral loads are very similar between those who never develop symptoms and symptomatic patients. Overall, the estimate is 25 to 30% of people excreting virus will never have symptoms. And so about 40% of all cases are now estimated to be from pre-symptomatic transmission. This is interesting new data, which hopefully suggests that we may see a decrease in cases over the summer. Exposure to simulated sun exposure found 90% of infectious virus is eliminated from stainless steel in 14 minutes. Indoors, that takes 3 to 4 days. Comparing solar irradiance in 359 countries, and a very strong correlation between the amount of solar irradiance or sun and lower incidence of COVID-19. Another major and growing issue is disproportionately affected populations. Nursing homes, residents make up 0.5% of the population, but 33% of deaths. In France, it's 50%. Meatpacking plants, 17,000 infected workers, increasing every day, 192 plants in 32 states with 66 deaths. Disproportionate effect on African Americans and Hispanics. In Chicago, African Americans make up 1/3 of the population, but sadly 72% of deaths. The Navajo Nation has the highest prevalence of cases in the country. Homeless shelters and prisons have been significantly affected. So clinically, 80% of cases are mild, but with large quantities of virus. 15% require hospitalization, 3 to 5% ICU admission, 2% mortality overall. But if you factor in those that are never symptomatic, it looks like the overall mortality may be 0.5%. But patients who have died, over 80% were older than 65, despite the fact they only make up 22% of cases. And 75% have an underlying health condition that puts them at greater risk. You can see here, starting at 50 to 59, the mortality goes from 1 to 4% to 8, and over 80, it's 15%. And comorbidities like cardiovascular disease, diabetes, chronic lung disease, and hypertension increase mortality. The study of over 4,000 patients from a single New York City medical center, the strongest hospitalization again, age over 75, a 69-fold increased risk of hospitalization. A body mass index of greater than 40 actually was a higher risk than congestive heart failure for hospitalization. For patients under 60, BMI is proving to be a significant risk. BMI of 30 is the definition of obesity. It doubled admissions and need for critical care. BMI over 35 increased the risk of critical care by almost fourfold. And this is clearly not like the flu. Even for younger people aged 20 to 29, the mortality rate for COVID-19 is 33 times higher than seasonal flu. Clinically, I think we all know about fever, cough, muscle aches, and shortness of breath. But note that fever is present on presentation in less than half of cases. So it's not a very sensitive screening tool. Very peculiar is this loss of smell and altered taste. It turns out that nasal epithelial cells display the highest expression of ACE2 in the entire respiratory tree. Altered sense of smell or taste has been reported just about 2/3 of cases. It can occur either before other symptoms, at the same time, or a little over a quarter after other symptoms. More frequent in women. Fortunately, it resolves in about 2 weeks. The other issue that we're seeing is this multi-system inflammatory syndrome in children. Well over 100 cases in New York City, more than 50 cases from the UK, large number of cases from Michigan. They have persistent fever and then a combination of a variety of symptoms: shock, diarrhea, abdominal pain, rash, cardiac and coronary artery abnormalities, hypoxia, and elevated CRP and ferritin. Fortunately, there's a very good response to intravenous immune globulin and steroids, and deaths have been quite rare, very much like Kawasaki syndrome. As far as diagnosis is concerned, polymerase chain reaction, or PCR, when it's positive, what it means is that genetic material of the virus has been detected, but it does not tell you whether the virus is alive. And even if it's alive, it does not tell you whether there is enough virus to be transmissible. PCR has a sensitivity of only about 75%. So a single negative PCR does not exclude COVID-19, especially early in disease. If the PCR is negative but suspicion remains high, then isolation should continue and resampling several days later should be considered. In New York City, among patients with initially negative PCR, 19% were positive on repeat. Only 58% of those who eventually tested positive by PCR were positive on the first test. Another study that on day 4 after infection, 60% of infected patients had a false negative PCR. At the time of symptom onset, it was still 38% falsely negative, and the best it ever got was 20% false negative PCR at day 8, and then progressively increasing false negatives after that. How long is viral shedding? It's directly related to severity in older patients. About a third had PCR for 20 days or longer after symptom onset. We've seen PCRs positive as long as 6 weeks. Milder cases, though, have clearance by 10 days post-onset in most cases. In small studies, when they actually look at culturing the virus, not just the PCR, there have been no positive cultures past 8 days. So the feeling is infectivity is about a week or 8 days after symptom onset. PCR can remain positive for weeks. Is that a concern for transmission? In a study of over 2,000 close contacts of COVID-19 cases, the attack rate was 0.7% with exposure before symptoms, 1% in the first 5 days of symptoms, but exposure 6 days or later revealed no infections in over 850 close contacts. Another issue is this repositivity, where you have negative PCR times 2 followed by a positive. A lot of these have been reported from South Korea and also sailors on the Teddy Roosevelt. Monitoring of 790 contacts of these 200 plus repositives found no contact that was newly infected. When viral cultures were done on 108 of these repositives, all were negative. Korean CDC no longer recommends isolation of repositives. So this is probably a situation where the PCR is on the margin of positivity, positive one time, negative the next, detecting dead virus. Antibody tests could be very helpful. We could determine which healthcare workers could safely return to work. We could staff nursing homes with immune workers. We could decide who could return to work, select donors for immune plasma, and determine the seroprevalence, whether there's herd immunity or not. There are many antibodies that are generated during infection. The critical antibodies are the ones that will inhibit viral growth, and we call those neutralizing antibodies. Unfortunately, at the current time, we do not have any idea what level of neutralizing antibodies provides protection from infection, and we have no idea how long this immunity will last. As far as antibody tests, the elderly and middle-aged had significantly higher neutralizing antibody titers than young patients. Higher neutralizing antibody levels were associated with more severe disease, and 30% of patients had very low levels of neutralizing antibodies. It's unclear if these people that never develop symptoms and those with low levels of neutralizing antibodies have protection from the virus. So, big question, social distancing, was it worth it? Closing down the economy cost $100 to $350 billion per month. A study that analyzed the daily case growth rate in all U.S. counties in the United States measured the effect of 4 types of social distancing: large event bans, school closures, closing restaurants, bars, and gyms, and then finally shelter-in-place orders. The study concluded that the U.S. would have had 35 million COVID-19 cases by April 27th, as compared to the actual 1 million cases. So a very significant effect of this social distancing. Most important was the shelter-in-place orders. School closures did not seem to affect the number of cases significantly. You can see here at the bottom, if we had instituted these measures 2 weeks earlier than we did, there would have been 11,200 deaths. 1 week earlier, 29,000 deaths, rather than the 65,000 deaths that we suffered as of May the 3rd. As far as reopening society, Harvard Roadmap to Pandemic Resilience estimates we'll need 5 million tests per day by early June to have a safe social reopening, and 20 million tests per day by late July to fully mobilize the economy. They recommend a testing, tracing, and supported isolation strategy to prevent cycles of opening up and shutting down the economy. Sadly, our current level of testing is about 350 tests per day, woefully short. The study recommended the development of a federal pandemic testing board to organize the supply chain and invest in testing innovation. On Sunday, the federal government announced that this would remain an issue for the states individually. So we have 50 states competing for all the factors in this supply chain rather than working together. Safe re-entry, it's going to require a new societal culture with an expectation of compliance with hand hygiene, screening, social distancing, and masks. How often we wash hands matters. Military boot camp washing hands 5 times a day decreased medical visits for respiratory infections by 45%. During the SARS outbreak in 2003, washing hands 10 times decreased infections even more. I've always liked this slide with the alcohol hand prep. We need to screen ourselves and self-isolate if we have symptoms. We don't need people coming to work with a cough. At Mass General, symptoms often very mild prompted 11,000 staff members to stay home and be tested. 1,400 tested positive. Despite over 1,000 suspected or confirmed COVID-19 cases every day, there was no association with being assigned to the COVID-19 wards. The most important risk actually was your zip code, where you lived. And I think that is true for many of the infections in healthcare workers. It's not at work, it's at home. Universal masking, this is a critical issue. A study of universal masking found a literally nearly perfect correlation between early universal masking and successful suppression of daily case growth rates. You could call this a mouth and nose lockdown instead of a full body lockdown. lifting shelter-in-place orders and maintaining social distancing without masking has been projected to increase the infection rate, with almost half the population eventually becoming infected. The green lines are those countries that have a universal masking culture, and some of those, like Slovenia and Slovakia, are countries that instituted universal masking but didn't have a culture for it. The gray are countries that did not do either. And you can see here across the top, USA, Russia, and Brazil, leading cases in the world, limited mask usage, and limited testing and tracing. Below, you have the countries with required or universal mask usage and testing and tracing. You can see much better control of this pandemic. Surgical versus homemade. First of all, a mask can prevent spread from an infected person. A surgical mask blocks about 99% of respiratory droplets expelled by an infected person. Cloth masks are effective, but only about a third as effective as surgical masks. The virus can only survive about 3 hours on cloth. The other issue is that masks can prevent infection of the wearer. Surgical masks reduce droplets from other infected persons by about 75%, and the cotton masks that we're making filter about half as much, but they also prevent the wearers from touching their mouth or nose. An international consortium of scientists suggests that if at least 60% of the population wore masks that were 60% effective in blocking viral transmission, the epidemic could be stopped. We're also going to need contact tracing. Estimate is at least 100,000 contact tracers. Each patient has about 50 contacts per case, starting 2 days before symptom onset. Currently, we only have 3,000 contact tracers in the US. Virginia is trying to hire 1,000. Patients and positive contacts would then be isolated. Contacts who test negative can be retested during incubation, or they could just continue voluntary isolation. And lastly, vaccines. There are over 100 in development. All different variety of platforms are being used. We'll look at 2. Moderna has a messenger RNA vaccine, which encodes a stabilized form of the spike protein. The vaccine has completed phase 1 trials at NIH. It's amazing to me that from the day of sequence selection as the foundation of the vaccine to the start of that phase 1 trial was a mere 63 days. Moderna has received almost $500 million in US funding to take this vaccine through trials. The patients did develop neutralizing antibodies at levels very comparable to convalescent sera. Vaccination of mice with this vaccine prevented viral replication in the lung, and phase 3 trials are expected to start in July. And lastly, we have an adenovirus vectored vaccine that's being developed by Oxford. They plan on starting phase 3 trials with over 30,000 people this summer. The US, interestingly, has made a big bet here, $1.2 billion for the production of 300 million doses to be purchased and stored by October until studies show whether it's safe and effective. So if it's safe and effective, if all goes by plan, we will already have 300 million doses prepared. Of course, that's a big billion-dollar bet. And with that, I will end.
Thank you so much, Dr. Oldfield, for that excellent presentation and overview. Just as a reminder, this virtual session is being recorded and will be available on our EVMS website later today. Please continue to submit your questions through the Q&A feature and click like on those questions that you see posted if those interest you as well. And now we'll transition to Dr. Michael Hooper, again providing the Sentara Norfolk General Hospital preparedness and protocols. Dr. Hooper.
Thank you, Dr. O'Mara, and I appreciate that overview from Dr. Oldfield, as always, a very concise and informative view of the science of this virus. So thank you again for having me. I've been in this community for the past 10 years, first with EVMS and now with Sentara. Happy to be part of this campus and a pleasure to be talking to all of you today. So thank you for giving me your time. So just to take us back and give us a little perspective of what we've been through the last couple of months, looking at March 8th, New York Times headlines, we had 500 cases across the United States with a total of 22 deaths, almost exclusively in one location in Washington State. Now, less than 3 months later, May 27th, yesterday, we had 98,938 deaths, with closing in on 2 million cases infected. So come a long way, and during that time period, we've seen really significant changes in our understanding of this virus, really significant changes in the healthcare landscape, and really significant changes in our societal response. And throughout that time period, Sentara, like all other healthcare organizations, has been trying to respond to that shifting landscape to make sure that we do what's best for the health of the community and the best for the people that are working within our buildings. So an overview of what we've done and what we've focused on, and again, this is very high level. There's tons of work that's gone into this by thousands of people. But very early on in March, Sentara adopted an emergency incident command structure that allowed for very agile decision-making, quick intake of information, and changes in the many processes and protocols going on around the hospital to keep patients safe and to keep the people who work in our buildings safe. Some of those early focuses, number one, which is extremely important, was the public health aspect of this disease. As you're aware, and which bears repeating, or is important to repeat, is this is a public health crisis. An ounce of prevention is certainly worth a pound of cure with this virus. Everything that we do as healthcare workers is incredibly important, but we are very far downstream of the true root cause of this pandemic, and the societal response stands to save many more lives than what the healthcare worker response will for this particular disease. So that's something that I bring up every time I talk about the treatment of COVID-19, is all of us are leaders in our community, and anything that we can do to stem the tide of this disease as this progresses, that will do more than anything we can do within these walls in terms of preserving life throughout our society. The next thing to stress was infection control and employee health were very early focuses for obvious reasons, and continue to be a major focus of Sentara. We put in a number of environmental control practices very early on to try to address this. We wanted to make sure that we protected our patients and also protected our workers from exposure to the coronavirus and to the COVID-19 disease that it causes. On the environmental side of things, we've done a number of things, as Dr. Oldfield mentioned, abundant hand washing, back to the basics, washing your hands, not coming to work sick, screening workers coming into the building with questions about symptoms, limiting visitors, limiting entrances, increasing the cycle of environmental cleaning, cohorting known ill patients together to try to limit exposure throughout the environments in the building, were all some high-level early things that we put into place to try to limit the spread of disease. The other thing that we dealt with very early on, which was something that was in the national news, were the challenges around personal protective equipment for the people working within our walls. So on the one hand, N95 respirators have been a part of the response of this illness. Very early on, the CDC recommended N95 respirator use when treating patients with COVID-19, and it became particularly clear that this was important in a subset of patients who are undergoing certain aerosol generating procedures, and that became a quick focus of the institution, as that supply chain for that type of respirator device was interrupted, with every hospital in the country, and indeed every hospital in the world, trying to secure the same supply of those devices and that equipment. So very early on, we did put a lot of processes in place to make sure that those N95s were being prioritized toward the workers who were taking care of COVID-19 patients and taking care of those patients that had the greatest risk of aerosolizing virus. We also put in several measures to extend the use of every N95 respirator to make sure that throughout the crisis that we would make sure that our workers had access to the respirators that they needed to keep themselves safe. The second thing that came along was masking, and masking in general was something that was always recognized to be important when treating these patients. But the idea of universal masking, as Dr. Oldfield mentioned, was something that the CDC got behind in April. And as we saw our supply strengthen, was something that we started enforcing throughout our building, first for healthcare workers, and then extending on to all patients and certainly all visitors once they were allowed back into the building. And that's something that we continue to do and recommend today. There were a lot of challenges overall with the PPE process, a lot of guidelines that went into place to make sure that PPE, gowns, gloves, every aspect of PPE was being used appropriately by people in the building. And again, we continue to do that today. And as our supply has become more reliable, we have become a little bit more liberal with its use. We continue to have very strict tables in place for the type of PPE that people should be wearing. And one thing that's become very important that we stress to everyone working now is that in every clinical encounter, we have workers wearing masks and wearing eye protection. And over and over again in our building and in hospitals throughout the country, what we see on the occupational health side of things is that if everyone is masked and everyone is taking appropriate precautions with eyewear when necessary, that exposure rate, that infection rate of workers plummets dramatically. And so just as the data that Dr. Oldfield shared, that is something that we're enforcing and something that we're maintaining within our buildings. On the employee health side of thing, one other issue that we've dealt with throughout this is, in addition to the concern that an infected patient would infect a worker, we have concerns that an infected worker will infect another worker, or that an infected patient will infect another patient. And so we've put in many strict controls with personal protective equipment, not only for patient encounters, but also when encountering your coworkers, because that is at least as large of a risk as it is when you have a patient encounter. So social distancing, masking, and eye protection are things that we are having in place throughout our building, whether for clinical encounters or not. The next thing that I wanted to speak about was testing capability and capacity at Sentara. So much like the nation, early on, the testing was very limited, and there was a supply of tests from the CDC that went to the departments of health across the country, but it was very limited in terms of the number of test kits that were available. And so there were very strict criteria on who could get tested, who could not. And early to mid-March, we saw LabCorp and Quest, some of the commercial laboratories, stand up a significant testing capability that then allowed some of the healthcare systems to test a little bit more broadly, Sentara included. Shortly after that, in mid to late March, we were able to stand up internal SARS-CoV-2 PCR testing, and we're able to therefore increase our capacity for testing with a prioritization initially on inpatients in our building who were symptomatic, who we had concerns of COVID-19. With expanded testing capability over late March and into April, we've seen our internal testing capability increase north of 1,200 tests per day that we're now able to do internally. And that's allowed us to do much more extensive testing on the inpatient environment. And certainly at this point, we can test any inpatient that we have any concerns of coronavirus or COVID-19 infection. We're also screening all of our surgical operations, screening patients for elective surgery or any planned operation for COVID-19 prior to taking them to the operating suite. We're continuing to screen all patients coming from a congregant facility, such as a skilled nursing facility, inmate in a prison or any other high-risk environment where we feel like their likelihood of having disease is greater than someone simply coming from home. We have multiple testing platforms that we've stood up very early on in this crisis. When testing was limited, we pursued a lot of redundant testing capability to make sure that we had that internal capability as early as possible so that we could take care of the community. One thing that we've seen over time is starting back in early March when testing was available from LabCorp, we initially saw a turnaround time of a couple of days, but as the entire country began sending more and more tests to those commercial labs, that turnaround time increased dramatically. When we were able to stand up internal testing in the later part of March, we saw that turnaround time come down substantially, and now we are able to pretty consistently offer a one-day turnaround or less when patients are tested for COVID-19 in our facility or emergency rooms or clinics. So testing policy, the PCR has really informed how we've used this test throughout our facility. So it's a very good and specific test. If you get a positive result, it is extremely likely that the patient has disease. One thing that you're probably aware of is that the sensitivity is only moderate, on the order of 70 to 80% in clinical use. And so the negative predictive value is very dependent on the disease prevalence in your community and also on the pretest probability that you have as a clinician based on that patient's symptoms and clinical presentation. So for that reason, we have to recognize that a negative test does not always lead to a negative clinical scenario, and the diagnosis remains a clinical and laboratory diagnosis, and we stress that to all of our providers to make sure that we don't make mistakes in identifying patients and thereby expose either other patients or workers to a patient who might still be infectious with the virus. In terms of other testing capability, we do have antibody testing in-house at Sentara. As Dr. Oldfield mentioned, there are challenges in terms of the interpretation of that test. We use a Roche platform, which has an emergency use authorization from the FDA. They tested about 5,000 samples internally to the company from patients in 2019 prior to the pandemic, where they had respiratory samples, and they found a very low cross-reactivity on the order of 99.8 specificity for coronavirus when they did their internal testing. So that does give us some hope that antibody testing will be useful, but much like Dr. Oldfield mentioned, we think that more studies are necessary to have 100% confidence in terms of interpreting those results. In terms of the care of COVID-19 patients, we very early on in this crisis put together a multidisciplinary task force that included pulmonary and critical care physicians, our critical care high performance team, some infectious disease providers, infection control nurses, general clinical nursing, pharmacy, and members of our laboratory staff to try to strengthen the protocols used across the organization so that we could use the best informed scientific way to treat patients. We are now on version 9 of that protocol, so much like healthcare systems across the country, as the data has evolved, as more studies have come in, as more anecdotal experience is obtained, we have amended that protocol to try to stay on top of the best science. And Dr. Merrick will be talking some about some of the specific aspects of this. One thing that I wanted to bring up was the risk of mortality for a confirmed case of COVID-19 has varied substantially across the globe, and that's varied based on testing capacity, demographics, and case volume relative to their health system capacity. So you saw health systems that were overwhelmed with very old demographics and saw very high rates of mortality. And alternatively, you've seen societies that have tested extremely aggressively case tracked early, protected their at-risk populations very aggressively, and have shown much lower mortality rates. Our best guess here, based on some guidance from the CDC and some antibody studies in some affected areas, puts the mortality rate for all individuals somewhere between 0.2 and 1%, depending on the expert that you listen to. Based on that, the risk and benefit of treatment has to be taken into account with the individual that you're treating. For an asymptomatic individual, their risk of mortality is negligible, and therefore introducing them to risk during treatment does not make a lot of sense. Similarly, a symptomatic but very mildly symptomatic individual also likely has very low risk of complications, very low risk of progression in many cases, and we have to take that into account when we recommend their treatment as well. With hospitalized patients, what we're seeing is an overall hospital mortality rate somewhere on the order of 10%, 9 to 10%, depending on the study you look at. And as you introduce risk factors, respiratory failure, increased inflammatory markers, or other organ failures, that mortality risk goes up. And the risk benefit of introducing potentially harmful treatments that have some side effects starts to shift in terms of wanting to treat patients. And that is indeed what our protocols have tried to reflect. The overview of our protocols is we monitor for inflammatory and coagulation markers, and this has been very much in line with the progression that we've seen from professional societies across the country and some of the other large health systems that have put out protocols. We have adapted our respiratory protocols very early on from an infection control standpoint. Many people were recommending early intubation of patients to close the circuit on their respiratory status and prevent harm to healthcare workers and other patients from aerosolizing virus. We have amended our protocols as it became increasingly evident that introducing mechanical ventilation was potentially harmful. And instead, we try to support oxygenation any way we can with minimal harm to the patient, including very early prone positioning. And I think that's where we've seen the entire country move in terms of their respiratory protocols. The hypercoagulability of this disease has become very apparent. And again, Dr. Merrick's going to be talking about this in some detail, but managing that hypercoagulability with some dose of anticoagulation in patients is something that we continue to wrestle with. Again, you want to risk stratify patients and make sure that the treatment you're introducing is proportional to the risk that that patient has of having a complication from disease. And we've moved from simply prophylactic anticoagulation to now targeted anticoagulation in what we deem to be a higher risk patients for clotting based on clinical gestalt as well as some biochemical markers. The inflammatory response of this disease is very well described and a driver of mortality. That's become very clear. Systemic corticosteroids for patients with respiratory failure continue to be part of the Sentara recommended protocol. And there have been multiple adaptations in terms of dosing and timing of those corticosteroids, and that will continue to change over time. In addition, there are other anti-inflammatory and cytokine modulating therapies that we continue to look at and will continue to look at as more data comes into view. Last is remdesivir had a positive trial in terms of duration of disease and received emergency use authorization from the FDA, as many of you are aware. We are using that at Sentara and have put together use criteria based on some level of respiratory failure and a lack of contraindications. And we look at patients on a daily basis across the system, as well as whether or not we have supply of drug, and are then trying to target the use of that medication to preserve the most lives possible. So that is all that I had today. Thank you very much again for letting me take the time to talk to you about the Sentara response to this epidemic. And with that, I'll hand things over to Dr. Merrick.
Actually, thank you, Dr. Hooper, for your tremendous leadership through this pandemic, and also thank you for your very informative update. Again, I want to thank the audience for your questions thus far. Please continue to like the posted questions that you see or submit your own questions. And now we will transition to Dr. Merrick. Again, he'll be talking about the major pathogenetic mechanisms in COVID-19 and approaches to therapy. Dr. Merrick.
I'm going to be talking about clinical syndromes and an approach to treatment. This is an overview of my talk, and I think the most important point is that this is a spectrum of disease. There are a whole bunch of phenotypes. COVID-19 is very much like polio. There's an enormous spectrum of disease. Secondly, the disease is a clinical diagnosis largely. I'm then going to highlight the immune dysfunction and thrombophilia as major pathogenic mechanisms. I'm going to review the stages of the disease and discuss the approach to each stage of this disease. For those who are interested, we have a protocol on the EVMS website. This can be downloaded. It's fully referenced. I can't discuss all the references today, but this document is fully referenced. So what's really important to recognize at the outset, Dr. Oldfield did touch on this, is that patients progress through various stages. There's the incubation phase, which lasts about 5 days. Some patients remain asymptomatic. Patients then progress to the symptomatic phase, characterized by fever, malaise, cough, headache, and diarrhea. From here, viral replication decreases. This is a really interesting phenomenon, that as patients progress from the symptomatic phase to the pulmonary phase, viral replication decreases, yet patients get sicker as a result of significant immune dysregulation. The early pulmonary course is characterized by shortness of breath, mild hypoxia, most notably an arterial saturation less than 94. Patients with a late pulmonary phase have progressive hypoxemia. So this is a nice overview of the various stages of COVID. The top is those patients who survived. The hatched columns are those patients who died. So this is nothing like the flu. You can see people on average remain febrile for 12 days. They have significant respiratory symptoms for up to 3 weeks, which is truly remarkable. Sometimes it can progress significantly beyond that. Typically, shortness of breath begins on day 6 or 7. This is a really key fact. So patients can appear to be improving and then develop dyspnea, i.e. shortness of breath. Now you notice that long delay between dyspnea and ICU admission. This is a problem because, as you will see, we need to treat this phase aggressively. And then there's the intubation phase, and you can see the mortality of patients who are intubated is close to 100%. So obviously this is what we strikingly want to avoid. So again, the stages of the disease. Now when they talk about contagious, this is viral shedding. And as Dr. Oldfield said, there's a difference between being PCR positive and having active viral replication. So maybe about 30% of patients are asymptomatic. They then progress to mild symptoms, severe symptoms, and the critical phase. It appears the sicker you are, the longer you shed the virus, and the later you have onset of your immune response. So as I said, there are a number of different phenotypes. And what we're going to talk about is the balance between your type 1 interferons and your pro-inflammatory cytokines, notably IL-6. So patients who are asymptomatic, they make interferon with low IL-6. As you can see, as patients become more symptomatic, the interferon production is less, the pro-inflammatory cytokine production goes up. Then there are a number of specific phenotypes. There is a thrombophilic phenotype. Patients develop severe coagulopathy, which we'll discuss. These people have an exceedingly high D dimer. The early pulmonary phase is characterized by increased IL-6 and ferritin. As they progress into the late pulmonary inflammopathic phase, they have very high IL-6 and ferritin. And then finally, we have a macrophage activation syndrome subtype, in which patients have very high IL-6 and exceedingly high ferritin levels. So what determines these different phenotypes? One is certainly age. Secondly is the patient's genetic makeup, and patients have been classified into various genotypes, the inflammopathic, the thrombophilic, the adaptive. Comorbidities play an enormous role: diabetes, cardiac disease. As Dr. Oldfield said, ACE2 expression is really important. There are a number of factors that affect ACE2 expression. Patients' baseline immunological competence. What appears to be quite interesting is patients' vitamin D status, which is largely dependent on your geographic place of residence. So people who live north of 40-degree latitude are at a much higher risk of having vitamin D deficiency, and those states in the US north of 40 degrees have a much higher risk of mortality from COVID-19. Patients' nutritional status and other unknown confounders. So this is a vital slide. I think this is very important and summarizes COVID-19. COVID-19 is something we've never seen before. It's a completely different animal. And one has to realize just how pesky this virus is. So on the right, you have common respiratory viruses. On the left, you have COVID-19. So what happens with, and these are studies from gene expression in human pulmonary cells, is that COVID-19 results in a very high expression of your inflammatory cytokines, chemokines, IL-6, IL-1. And you compare this to your common respiratory viruses, including influenza, it's significantly greater. But what makes this virus so unique and so smart is that while it upregulates the inflammatory response, it downregulates the expression of interferons. And interferon type 1 and type 3 are the major host defenses against viral infection. So COVID, as opposed to influenza, results in a limited antiviral response compared to, say, the influenza virus. So there is a marked imbalance between the host immune response and getting rid of the virus and this profound inflammatory response. Again, this slide again demonstrating the marked immune dysfunction, dysregulated immune response, which can be driven by IL-1, in which you get macrophage activation, or predominantly IL-6, you get this remarkable immune dysregulation. Following biomarkers is really important as both from a diagnostic and therapeutic point of view, and COVID-19 results in very specific biomarkers. As we said, this is a study looking at survivors and non-survivors. D-dimers go up very high in non-survivors. Patients who die have a low lymphocyte count, have high IL-6 levels, and high serum ferritin. Probably the most important biomarker is CRP. So CRP is induced largely by IL-6. So it's a reflection of IL-6 levels. So the CRP is important for tracking the disease with time. It stratifies patients into disease categories, and also the CRP level correlates very closely with the changes on CT scan. So the question is, what does COVID do to the lung? So this is not ARDS, this is not viral pneumonia. And it's one of the early mistakes was to treat patients as if they had ARDS. So on the left is what Dr. Gattinoni calls the L phenotype, which is typical of patients with COVID. This is not ARDS. On the right is a CT scan of the H phenotype, or typical ARDS. Now, patients with the L phenotype may in fact progress to the H phenotype due to ventilator-induced lung injury or due to disease progression. So I'm just going to go through some CT scans which illustrate this disease. So the pattern on CT scan is specific. You can look at the CT scan and almost with 100% certainty say this is COVID. It's such a specific pattern. So what one sees is peripheral ground glass, multi-site, multi-lobar ground glass opacities. So you can see top left, top right, then bottom left. As the disease progresses, you get coalescence and extension of these ground glass opacities. However, they start off being peripheral. The chest x-rays again show very peripheral ground glass hazy disease. This is very specific for COVID. Again, the top left panel is a CT scan, which is absolutely typical of COVID. You see these patchy ground glass peripheral opacities. There's really no other disease that does this. With progression, one gets much more extensive disease, top right and bottom left. And as the disease progresses, it actually changes its characteristics into a disease which is less responsive to steroids, as we'll see. And patients develop a fibroproliferative phase with traction bronchiectasis. So SARS really causes an organizing pneumonia. So what pulmonologists talk about is an organizing pneumonia. So this is not typical viral-induced lung injury or typical pneumonia. This is an organizing pneumonia. On pathology, you see diffuse alveolar damage, but it's distinct from typical ARDS in that you get a fibroproliferative response. So these little arrows indicate fibrous plugs within the alveoli and bronchial ducts. And as well, if you look at the blood vessels, they get a vasculitis, profound involvement of the pulmonary endothelium with a vasculitis and thrombosis. And this underlies really the pathophysiology of this disease. So with time, you get progressive pulmonary involvement, and with time, it becomes more and more irreversible, hence the need to treat these patients early with an anti-inflammatory approach. So I'm going to just present a single case that we saw recently. This is a 65-year-old female presented with typical symptoms, fever, headache, myalgia, these peripheral infiltrates on her chest x-ray. She tested COVID negative ×2. She was sent home on antibiotics. She then presented again with progressive symptoms, cough, fever, not feeling well. Again, you see the peripheral infiltrates on chest x-ray. You can see she had an extensive molecular diagnostic panel. The PCR was negative. When she presented, they thought they'd do an antibody. This was negative. She was then sent home again, although clinically she had COVID, with a diagnosis of bacterial pneumonia and started on a different antibiotic. She then presented 4 days later. You can see with a classic CT scan and chest x-ray showing progressive pulmonary involvement. Now the patient was hypoxemic. Her antibody had turned positive, and as you can see, her CRP, which closely tracks disease severity and pulmonary involvement, had now gone from 1.3 to 13.9. At this point, she was admitted to the ICU. She was treated with a trifecta of corticosteroids, ascorbic acid, and low molecular weight heparin. You can see that immediately after starting therapy, there was a rapid decline in her CRP with dramatic improvement in her chest x-ray. Again, highlighting this is an inflammatory lung disease that responds to anti-inflammatory therapy. Looking at the coagulation, this is a thromboelastogram done on a patient on admission to the ICU. This shows a marked hypercoagulable state. Patients with COVID-19 present with a hypercoagulable state. This is a patient who presented with COVID symptoms, fever. However, he had a profound tachycardia, RV dysfunction, and a CTA showed a large pulmonary embolus. This is a study published today, basically reiterating what we're saying. that routine thromboembolism prophylaxis is inadequate to treat the hypercoagulable state of COVID. These patients need full anticoagulation. So we're going back to transcriptics and genomics because it bears enormously on this disease. So this is another study in which human pulmonary cells are exposed to the SARS-CoV-2 virus. They looked at genes that were up and down regulated. Again, what happens is your interferons are down regulated and your inflammatory genes, cytokines, chemokines are up regulated. However, what we're now talking about is medicine of the future. So in this study, what they did is they took that genomic profile and they tested it against a bank of over 1,000 medications to see what molecules or what medications specifically target those genes that are up and down regulated and target the disease process. And that medication actually which had the highest hit with an enormously low p-value was methylprednisolone. So again, highlighting the inflammatory response and that using an anti-inflammatory agent like methylprednisolone basically reverses these genomic effects. This is a study published yesterday looking at the effects of glucocorticoids on mortality in SARS, again highlighting marked survival advantage with glucocorticoids. So the treatment largely depends upon the stage of the disease the patient's in. In the early symptomatic viral replicative phase, it would be inappropriate to use anti-inflammatory therapy. But as you see, what happens is the degree of viremia diminishes, the inflammatory response increases. So the approach depends upon what phase the patient is in. In the early symptomatic phase, there may be a role for antiviral therapy. However, as the patients progress into the pulmonary phase, one needs to start anti-inflammatory therapy. And the earlier the better. As I said, the longer you delay, you get progressive lung involvement. The earliest and most important sign is desaturation. So a patient who desaturates either spontaneously or with ambulation to a set of less than 95 on room air needs to initiate anti-inflammatory therapy. So as we said, the treatment depends upon the stage, the early viral replicative symptomatic phase may be appropriate to use antiviral therapy. As they progress into the pulmonary phase, one needs to use anti-inflammatory immune modulating therapy. It's outlined on the slide and in our handout, so that the role, which we'll talk briefly about antivirals, is somewhat unclear. In terms of anti-inflammatory therapy, the trifecta is methylprednisolone, low molecular weight heparin, and vitamin C. Vitamin C is quite unique in that in addition to down-regulating the immune response, it actually upregulates interferon, so it restores immune balance. So vitamin C is one of the few agents which actually has this effect. This is an example of a patient of ours in whom the corticosteroids were stopped prematurely. You can see the CRP fell dramatically, but we then restarted steroids, again with showing the enormous rapid response. So these people, this is not your regular pneumonia. These people require a prolonged course of treatment due to this prolonged inflammatory phase. In our protocol, we've divided treatment into prophylaxis, treatment of mildly symptomatic patients at home, and I point out the fact that we would recommend home pulse oximetry monitoring in patients who can do this, and ambulatory desaturation should prompt admission. We then have mildly symptomatic patients on the floor. These are patients who've entered the pulmonary inflammatory response, and in this phase, we recommend initiation of corticosteroids. Once they then progress to the ICU phase, they require aggressive anti-inflammatory treatment. This is the trifecta of methylprednisolone, ascorbic acid, and full anticoagulation, with additional treatments which are optional. We try and avoid intubation at all possible using high flow nasal cannula. We accept flow rates up to 60 to 80. A trial of epoprostenol, and we attempt proning. So this is high flow nasal cannula together with cooperative repositioning or proning. And lastly, this is a study recently published in Lancet looking at hydroxychloroquine. However, what I want to point out is those factors which are associated with an increased and decreased risk of death. As we see, BMI is an important predictor. Female sex is protective. Blacks and Hispanic, a higher risk. Concomitant comorbidities, again, significant increased risk. What's interesting is ACEs and ARBs. It appears ACE inhibitors reduce your risk. Angiotensin receptors are neutral, and statins have a protective effect. Finally, just to finish on remdesivir, which Dr. Hooper briefly mentioned, what people don't know is that halfway through the study, the investigators changed the primary outcome measure. This is highly irregular to do in a prospective clinical trial, removing death from one of the ordinal endpoints. So the primary endpoint in the study was not patient-centered, it was not a biomarker, it was not viral clearance, but a Wall Street-defined endpoint of days to recovery. And with that, I will end just again to re-emphasize COVID presents with a vast spectrum of phenotypes, the clinical diagnosis, immune dysfunction caused by this hyperinflammatory response together with increased clotting. The treatment depends upon the stage of the disease. And with that, I thank you.
Excellent. Thank you so much, Dr. Merrick, for that very educational presentation. What a panel, right, everyone? Amazing. So now we begin our question and answer session to address our audience's inquiries. We will address as many questions as we can during the remaining time, but for any questions that we do not get to, we will be sure to post the answers when we post the, where we post the recording. So we'll start with a question that had several likes, initially posed by Dr. Paul Aravich. Please comment on the neurological and behavioral complications of COVID-19, for example, olfaction and underlying risk of mental illness, addiction, and dementia.
You want me to address that?
Sure, yes, Dr. Oldfield, thank you.
So I have not come across any good data, pathologic data on the olfactory nerve or nasal biopsies, but I think that part of the issue is that very high ACE2 receptor level in the nasal epithelium, and probably virus affects the olfactory nerve. As far as psychiatric issues are concerned, like with many severe viral illnesses, there's significant deconditioning. There's a long time to recovery after people go home, and I think significant associated depression. As far as underlying depression, other psychiatric illnesses, alcohol, drugs, I think all of those are on the increase with our social isolation. Problems with spousal abuse, child abuse are clearly on the increase. So this is a multifactorial disease as far as society is concerned, not just the individual infected patients.
Thank you. Dr. Karen Williams asks, do you recommend screening surveillance with RT-PCR? I believe that was in response to Dr. Oldfield.
Yeah, I don't recommend it. It's mainly because of that high false negative rate. So you could get a sense of false security. Even at the peak, 20% of people have false negatives. And as Dr. Merrick mentioned, that one patient was admitted twice, treated for bacterial pneumonia. And in fact, all along, it was COVID-19 with a false negative PCR. So I don't think we should be screening with PCR.
Thank you. This is a question probably for Dr. Oldfield and Dr. Hooper from Dr. Ed Pelosa. For pre-op COVID-19 testing, which rapid point of contact same-day test would you recommend with the best sensitivity and specificity to minimize false negative results?
That's for Dr. Hooper. He's been dealing with this regularly.
So right now we're utilizing the PCR for that purpose. It is not a point of care test at this point at Sentara with the platforms that we're using. So we do require a one-day turnaround to reliably get that done for all of our preoperative testing. There's also antigen testing on the market. We do not have experience with that yet, but there are a lot of published reports of significant problems with sensitivity with the antigen testing. So I think at this point, if you have access to a fairly quick turnaround for PCR testing, it is the preferable method. That being said, as we mentioned, the sensitivity of the PCR testing is not perfect. And so even in a negative tested individual, we have to take some precautions, particularly if you have a high prevalence of that disease in your community. And one other thing I just wanted to say about screening testing on top of what Dr. Oldfield had mentioned is I agree completely with Dr. Oldfield that the individual-based screening, you have to take that with a grain of salt because of the performance of the test. There probably is still a role from an epidemiologic public health standpoint for screening certain high-risk environments and communities so that you know what's going on and can catch outbreaks very early on.
Thanks, Dr. Hooper. From Dr. Vanessa Blow, what is the best strategy to screen or test on university campuses with students back on campus? For example, daily temperatures, rapid tests based on home community, underlying conditions, etc. I believe that was in response to Dr. Oldfield's reopening society.
Yeah, so I would certainly screen as far as the symptoms are concerned with cough, shortness of breath, myalgias. As I mentioned, fever is less than half at presentation of symptoms, so it's not a particularly good screen. And we have a significant questionnaire that everyone returning to the EVMS campus will complete, and we're going to combine that with universal masking on the EVMS campus. I think that will help. But we don't plan on doing either PCRs on returning students or antibody testing.
Great. Thanks, Dr. Oldfield. Dr. Marisa Galicia Castillo asks, are more vulnerable populations, our geriatric population, those with chronic illnesses, tend to be more isolated? Please comment on the best way to interact with them outside of virtual contact.
Yeah, this is a really difficult situation with people very ill in the hospital and you can't visit them. People in nursing homes where the nursing home is completely locked down, there are no visitors allowed. So I think, for my mother, who's going to be 101 in June, we've actually got her a computer, and her aide helps set up Zoom conferences with the family. I think that there are a number of ways, but we need to maintain contact even if it's not face-to-face.
Thank you, Dr. Oldfield. Dr. Ruben Manuel Luciano Calongo asked, recovered ARDS and MERS patients showed permanent lung impairment years after resolution. Early reports from Italy indicate that 30% of recovered COVID have persistent areas of fibrosis. Is there a possible role for an early antibiotic treatment in patients with severe COVID?
Maybe I'll answer that. So it seems that unlike ARDS, where patients have full return of normal pulmonary function, these patients progress to a fibroproliferative response. So there may actually be a role for antifibrotic therapy. However, obviously that's completely theoretical and we have no data. But obviously as we get more experience and we have more patients who have chronic lung disease, these people may seek the attention of pulmonologists and this may be a therapeutic option. Dr. Hooper used to be a lung doctor. Would you like to comment?
Yeah, so I agree that there's a hypothetical rationale there. I think that is one with the side effects of those medications that would need to be studied to give us a little more information. I think at this point, what I would recommend to prevent that is just very early recognition and treatment of the inflammatory process as we had described, Dr. Merrick, particularly in some detail. There is also an equivalently good rationale that treating patients earlier and preventing that fibroproliferative stage would be the best way to approach that.
Great. Thanks, Dr. Hooper. This is a question for Dr. Oldfield from MK. Thanks for your talk. I have seen PCR testing being positive and negative every other time. Is there any explanation, especially for hospitalized patients?
Yeah, so I think this goes back to the repositive. In other words, you're just on the margin of this PCR test, which has only about 70% sensitivity. So one is negative, you're below the level of the test being able to detect it. The next one's a little higher. And this is all dead virus, remnants of virus, and not infectious virus. So as I said, the South Koreans basically no longer recommend isolation of these repositive people as long as they're out past 8 days from the onset of symptoms.
Thanks, Dr. Oldfield. Dr. Shaw asks, in response to Dr. Merrick's discussion on genotype responses, are they related to certain race? They had a patient tested positive for COVID-19, but the inpatient test within 3 days tested negative. How accurate and reliable are all these different tests for COVID-19?
So maybe Dr. Oldfield can talk about the different sensitivities in different populations. There's no question that this is a markedly heterogeneous disease. Part of this may be racially and genetically determined. For example, we know that people of color have a much higher mortality and more severe disease. This may be in part related to vitamin D deficiency because of the melanin, they cannot make vitamin D in the skin as efficiently. Obviously, there are a whole host of other socioeconomic and demographic factors, but clearly race may affect your immune response as well as other nutritional factors. In terms of testing, I'd hand it over to Dr. Oldfield.
Again, this test has a significant issue with sensitivity, and the earlier after infection, the higher the rate of false negatives. So unfortunately, we're dealing with an imperfect test. As far as vitamin D, which Dr. Merrick mentioned, it's been shown that African Americans, about 80% are vitamin D deficient. So that may be a critical issue in some of this disparity.
Thanks, Dr. Merrick and Dr. Oldfield. Another question for you, Dr. Oldfield, from Dr. Ruben Manuel Luciano. Many recovered patients with 2 negative tests test positive again to RT-PCR. Do you think that this is a viral adaptive mechanism to develop chronic infection in the host?
No, I don't think so. I think this repositive issue, the PCR can't tell you whether it's alive or dead, and I think this is dead virus, and you're just on the margin of the ability of the test to be positive or negative. So, no, I definitely do not think it's going on to a chronic phase.
Right. Thank you, Dr. Oldfield. From Dr. Shaw, should we consider patients at high risk to discontinue ACE or ARB for hypertension?
Yeah, I think all of the organizations, the American Heart Association, and others have all recommended if you're on an ACE or an ARB, stay on it. And although there is data that suggests that in particular the ACE inhibitors may improve outcomes, there's still a recommendation if you don't need it for hypertension, don't start an ACE inhibitor or an ARB.
JD asks, should mildly symptomatic, likely COVID patients be started on hydroxychloroquine when discharged from the ED? And should we also recommend vitamin D, zinc, vitamin C for people to take over the counter at home?
Yeah, okay, I'll answer that. So the second part first, because that's easier to answer. So I think there's evolving data that vitamin C, vitamin D, zinc may improve the immune status, may mitigate against getting COVID. So it seems like it's an enormously cost-effective intervention with very little downside. You know, these drugs are exceedingly safe. And I think particularly in nursing home patients, patients who are at exceedingly high risk, they need to do whatever they can to improve their immune system and reduce their chances of developing severe disease. In terms of hydroxychloroquine, that's really a can of worms, and I'm sure Dr. Oldfield would agree. I think we can now say confidently that there's no role for hydroxychloroquine in hospitalized patients. I think we can close the door on that one. What we don't know is if there's a role for hydroxychloroquine, one in prophylaxis. So there are a number of studies in which they're giving hydroxychloroquine to healthcare workers or other people at high risk. Hydroxychloroquine has a really long half-life, so you can take it once a week. The second question is if you give it to mildly symptomatic patients early in the disease, will this prevent progression? And it's theoretical, but we really have no data. And I think because of the potential cardiac arrhythmias associated with hydroxychloroquine, it's probably best to reserve that treatment to the confines of a clinical trial. I'm sure Dr. Oldfield will agree with that. It may have a role, but the recent studies have highlighted the increased mortality and cardiac risk with hydroxychloroquine, and I think that then calls for some degree of caution. Would you agree, Dr. Oldfield?
Yes, there have been a number of large studies out of New York City with over 1,000 patients that showed not even a signal of a positive effect, but increased side effects. Hydroxychloroquine in vitro has activity against the virus, but it also has activity against influenza, chikungunya, and dengue. And there were trials conducted against all of those, influenza, chikungunya, and dengue, and it had no effect on any of those viruses. So it seems like hydroxychloroquine, there's a big disconnect between in vitro activity and its ability to perform in vivo in humans with the disease.
Yeah. And I would just add on, our multidisciplinary group at Sentara looked at this and all came to exactly the same conclusion. We'll obviously pay attention to any new data that comes out that could shift our thinking, but right now we are not using that in clinical practice.
Thank you, all three of you. Is there anything known about the comorbidity of HIV with COVID-19? Specifically, are children with HIV who have negative viral loads at increased risk of disease severity?
And so there have been a number of trials, a number of studies of HIV patients that have been infected with COVID-19, and they have showed that outcomes are basically the same, whether you're HIV positive or HIV negative. So HIV itself, in particular, in a well-controlled patient, is not considered a risk factor for a worse outcome. I'm not aware of any data specifically in children, though.
Thank you. And it looks like our last question for Dr. Oldfield. It looks like there's many different possible vaccine candidates using different technology. With the accelerated development of all these vaccines, should we be concerned about their efficacy and possible side effects?
Well, certainly that's the number one issue. First of all, is it safe? So this is going to require large phase 3 trials to determine safety. But there's no reason to think this is going to be more toxic than other vaccines generally. It'll likely be a local reaction. Efficacy is a much bigger question, at least in mouse models, in rhesus macaques, And in development of neutralizing antibodies, they all look like they are producing a response. Interestingly, people have talked about challenge trials where you actually have young people willing to take the vaccine and then be challenged with SARS-CoV-2. I'm not going to be the first one to volunteer for that. I think the developments are very interesting, and I think we're going to get a positive result. How we're going to sort out which of the 100 candidates is the one that you spend $1 billion on and immunize 1 billion people, that's an open question. Interestingly, a recent survey, one showed that only 20% of people would not take the vaccine even if it was effective, and another study showed that 50% of people were not planning on getting the vaccine. So it's an odd situation. I would certainly be at the head of that line if I was allowed to get a vaccine that had been shown to be safe and effective.
Excellent. And that actually concludes our question and answer session. Again, everyone, please join me in, oops, hold on, wait, one more question just popped in. Let me get that. Can you please email the link for this talk? Absolutely. Again, please join me in thanking our excellent panel for their time and expertise. Thank you to the audience for joining us and for all of your questions. And special thanks to our EVMS AV staff for their support. Again, this webinar has been recorded and will be available on our EVMS website later on today. Thank you so much again, everyone, and take care and be well.
Thank you, Dr. Romero.
You're welcome.